Hello ladies and gentlemen, my name is Margaret Clark. I'm the Director of Home Therapies from Fresenius Medical Care, South Asia Pacific. So I'm going to talk about fluid management in our peritoneal dialysis patients. We're going to look at some risk factors, barriers to PD growth, the current fluid status in PD patients, factors governing ultrafiltration, and I'm going to give you a practical tool how to assess fluid volume, and then we'll look at strategies to preserve the residual renal function. So what are the risk factors faced by our dialysis patients? So on the left we can see the cardiovascular risk factors are impacted by salt intake, which causes our patients to drink more, and then they get this hypovolemic state, and often there's a failure to diagnose hypovolemia, failure to achieve normovolemia, and the patient often requires more antihypertensive medications. And this is a vicious circle leading to volume overload, hypertension, and left ventricular hypertrophy and cardiovascular disease and mortality in our patients. Then on the flip side of the coin, we have the nutritional risk factors, inflammation being the cause, leading to loss of appetite and high protein catabolism, hyperparathyroidism, and insulin resistance, leading to malnutrition, which is a reduction in fat and muscle mass, and increased extracellular volume, also leading to an increase in mortality. So in clinical practice, malnutrition is a common problem with our patients with end-stage renal disease, and they say that about 10% of our patients are severely malnourished and 33% are moderately malnourished. So this causes body weight loss and alterations in the body composition. So they have a reduction in fat mass and muscle mass and an increase in total body water. And that leads to an increase in extracellular water. And the causes may be inadequate dialysis, decreased protein and calorie intake due to loss of appetite, loss of amino acids in the dialysate, inflammation, and comorbidities. Malnutrition leads to an increase in mortality. They have more frequent hospitalisation, impaired wound healing, and are more susceptible to infection, and they don't rehabilitate particularly well. So the big problem is salt, because in this modern age we eat a lot more fast foods, we consume a lot more salt, and this has the problem because when you eat a lot of salt you naturally want to drink. So this increases blood pressure, increases the risk of cardiovascular disease, and is the major cause of heart disease and stroke. So in the US, if they restricted salt by 50%, it would save 150,000 lives per year, which would reduce the medical care costs by 1.5 trillion over 20 years. So volume overload, hypertension and anemia leads to left ventricular hypertrophy, which leads to cardiovascular disease, which is the leading cause of death amongst our dialysis patients. So, and what happens is they get this increased pressure in the ventricles and volume overload, causing the cardiac disease and eventually mortality. You can see here in the diagram. Now on the right hand side we've got this Foley's graph where we can see that a patient who's around 25 years old on dialysis has the same mortality as a 85-year-old in the general population, which is quite staggering. So looking at barriers to PD growth, we know that technique failure is a significant barrier to PD longevity and PD prevalence growth. And it's usually often related to problems in volume management. So they lose the residual renal function and they lose the urine volume. And then they may lose their ultrafiltration capacity. So it's fluid overload is the most important factor in causing hypertension. And this may cause our patients to use more hypertonic bags, which negatively impacts glycemic control. So can we manage volume issues better? So euvolemia or normovolemia is probably a more important adequacy parameter than small solute clearance or K/V urea. Fluid status, not small solute clearance, predicts outcome. And fluid volume overload and dialysis modality are independent predictors of mortality in our patients. So this graph from Edwina Barr shows the importance of not only ultrafiltration but also sodium removal. So on the left we've got patients who have an ultrafiltration of less than 750 mils a day had a higher mortality than patients who had more than 750 mils ultrafiltration per day. And then on the right, the graph shows the sodium removal in relation to the transporter status. So high transporters have the lowest sodium removal and therefore the highest mortality rate compared to low transporters who have the highest sodium removal and the lowest mortality rate. Now, the CAN USA study or CANUSA study demonstrates that residual renal function correlates with the relative risk of death. So this next slide is the CANUSA study, which many of you are familiar with, publication by Joanne Bargman. We can see here that a 12% reduction in relative risk of death was achieved when the GFR was greater than 5 litres per week, and that we had a 36% reduction in the relative risk of death when the urine output was more than 250 mils per day. So this really demonstrates the importance of residual renal function and how we need to preserve it in our peritoneal dialysis patients. This next slide is taken from the EuroBCM study that was done in Europe. The leading author was Van Biesen. This study looked at 639 PD patients from 28 centres. And we can see by the graph that only 40% were within the normal hydration range. In the right, we see that 53% of patients were overhydrated and 7% were dehydrated. There was a wide scatter in the relationship between blood pressure and hydration. And 39% were hypertensive and overloaded, but 25% had normal blood pressure despite severe overhydration. So often it's difficult to predict what's happening with the hydration when they have a normal blood pressure. So this study concluded from this trial that high blood pressure alone is not sufficient to detect fluid overload, that the PD prescription seems to be less relevant for fluid status than expected, that ultrafiltration and urine volume output are not associated to fluid status, that fluid status is not only determined by fluid removal, but also salt and fluid intake, and that more focus has to be put on this salt and fluid intake. So the authors concluded that the BCM was an important tool for managing our patients on peritoneal dialysis for detecting fluid overload. So fluid homeostasis in PD, so the majority of our PD patients are actually fluid overloaded. This disruption of volume homeostasis, we need to consider, is it a failure of the patient to comply with dietary and fluid restrictions? Is it the failure of the prescription? It's not providing enough ultrafiltration, or is it the peritoneal membrane that's not responding to the osmotic stimulus? So fluid overload is a clinical syndrome with multiple causes. It is the inability to maintain target or dry weight and an edema-free status. Dry weight is often determined by clinical examination, evaluation of blood pressure and trial and error. So causes of fluid overload in PD can be related to excessive salt and water intake, loss of residual renal function, cardiac disease, non-compliance with the prescription, dialysate leak, catheter malfunction, and so on. So when you're looking at trying to manage ultrafiltration failure, there's many factors, and we need to remember that ultrafiltration failure is not just a failure of the peritoneal ultrafiltration capacity. We need to look at all the other possible causes. So the factors influencing fluid balance in PD patients, so they have their intake of salt and water, and the output that we measure is the urine and the ultrafiltration. Remember, they also perspire. And then every day our patients measure their ultrafiltration or returns on the bags, their blood pressure and their body weight, and they record this in their record book. But this may often lead to the wrong patient fluid status. Malnutrition may cover fluid overhydration. All patients need to be considered. We need to look at the adipose tissue mass, the lean tissue mass, and the body mass index. So the body composition monitor is a useful tool that can help you manage fluid status and reduce hypertension in your PD patients. It assists with dry weight assessment, determining the degree of fluid overload, and measures nutritional parameters such as your lean tissue index, fat tissue index, and body mass index. So now I'm going to tell you about a take-home assessment guide, a practical way to assess and correct fluid status. So remember that intake is salt and water, and fluid balance is the balance of intake and output. So the output is our urine and our ultrafiltration. So close monitoring is required. So this is where you may find the body composition monitor useful, that we need to control what goes into the patient and monitor what comes out, and not just look at ultrafiltration. And we need to individualise the prescription. So one prescription doesn't fit all patients. So step one is assessment and trend. So this is to get a better understanding of what's happened to our patient. So this is where we need to weigh our patient, take their blood pressure, perform a fluid assessment and a BCM measurement. Step two is to control intake. So this is where we need to provide education to our patients regarding the intake of salt and water. And step 3 is optimizing the output. So here we need to adjust the prescription. So for example, if they're a high transporter, it may be better to use CAPD with a dry night, for example, or APD with a dry day. And we need to preserve the residual renal function. 1, 2, 3. So this chart here is a clinical pathway which can help us manage the different types of patients. So on the right we have their fluid overhydration, which is more than 1.1 litres on the BCM. So with these patients we need to reduce their salt and their fluid intake and provide a lot of education. We need to preserve RRF, increase or start diuretics, and adjust the prescription, and maybe even assess the membrane. And we need to provide a more frequent hydration assessment using the BCM until the dry weight is achieved. On the left we have dehydration, which on the BCM is greater than minus 1.1 litres. Again, these patients need to drink more. They may need more salty broths. We need to preserve residual renal function, as dehydration can knock off the native kidney. We may need to decrease or stop loop diuretics, adjust the prescription so they're only using the lowest concentration of glucose, and provide more hydration assessments using the BCM until the dry weight is achieved. Now in the middle, this is the group that's in the normal range. With these patients, they can maintain their current salt and water intake, continue to preserve residual renal function. If they're on diuretics, they can continue with their current prescription, and usually monthly hydration assessment is sufficient to prevent complications. This is 7 steps information pathway for patient education from Tawang, from ISPD in 2013 in Taipei. So he advocates that you educate your patients and, you know, give them a lot of coaching, give them a lot of praise, and provide options. I normally like to show the patient the reading from the BCM so that I involve them in the decision making. You need to negotiate and set goals that are adjustable, and implement and motivate and provide ongoing CQI. Just some tips regarding the right foods for patients. So I normally advocate fresh or frozen vegetables without added salt. Use low or no salt canned vegetables. You can encourage them to put the vegetables into the colander and rinse them under fresh water and cook in more fresh water. Avoid fast foods or frozen dinners, any deli meats. Choose fresh meats and fish. Check the labels and avoid products that are injected with sodium. Avoid adding salt to the cooking. Don't put salt on the table. Encourage them to use other herbs for flavouring. If you're eating out, encourage them to have the meal prepared without salt. And do not add soya sauce, salt or chili or any tomato sauce to the foods. And read the labels of processed foods. Avoid foods with sodium listed as one of the first 5 ingredients on the packaging. So regarding the salt and water restriction, I normally restrict the oral intake of to 1 litre per day if the patient is anuric. The salt restriction should be about 5 grams a day, which is 1 teaspoon. You can encourage the patients to keep a diary. Make sure they're taking their weight and blood pressure daily and recording it. If the patients are overloaded, normally I restrict their intake to 600 mils per day until they're euvolemic. So some tips, I usually get them to use a smaller cup. Remember that gravies, soups, jellies, ice cream are all fluids, so you need to take that into account. And they can suck ice instead of drinking fluids. And your diabetics, you need to keep the blood sugar below 10 because hyperglycemia can induce thirst. So what are the strategies to preserve residual renal function? Because residual renal function is very important in peritoneal dialysis to improve our patient outcomes. So the use of ACE inhibitors, ARBs, and calcium channel blockers, the use of loop diuretics prevent peritonitis, careful use with the use of radio contrast dyes or any nephrotoxic drugs, stop smoking, and in some countries we use ultra low GDP solutions. Remember that dehydration can cause loss of residual renal function and should be avoided. So in conclusion, fluid overload is common in our PD patients and needs to be addressed. So remember the 3 points: first, patient assessment, then control intake, and finally optimise the output. Thank you very much.